I'm here to talk to you about deep brain stimulation patient selection and the surgical technique as I do it. The topics covered include the indications for DBS, the process flow for surgery, and the steps of the procedure. To start with, what is deep brain stimulation? It's a high frequency pulsatile monopolar or bipolar electrical stimulation administered into deep target nuclei through stereotactically placed electrodes, which can be activated or deactivated using an external magnet. The exact physiology is unknown, but it is probably inhibition and not stimulation. The primary indications include Parkinson's disease, primary generalized dystonia, essential tremor, drug-resistant epilepsy. These are all FDA approved indications, including Tourette syndrome. It is increasingly coming into the realm of psychiatric indications like obsessive compulsive disorder, drug-resistant major depression, and post-traumatic stress disorder and addictions. It has also been tried in conditions like minimally conscious state. I will restrict the remit of my presentation to Parkinson's disease. As far as the ideal patient is concerned, he or she should be suffering from idiopathic Parkinson's disease and not one of these secondary or Parkinson's plus syndromes. There should be a reasonable response to levodopa, though typically the patients have significant on-off phenomena, including on-dose dyskinesias and off-dose painful dystonias. The Unified Parkinson's Disease Rating Scale helps give an objective idea about the severity of the disease, and DOPA challenge testing also helps us objectify our inclusion for the surgery. Who are all excluded? Apart from those who are anesthetic risks or of very advanced age where this will not give a good quality of life for a reasonable period to worth taking the risk of surgery. Those with severe brain atrophy, ischemia, those with pre-existing impulse control disorders, major depression, dementia, are the ones who are excluded. Overall, the patient and family members should have realistic expectations of an improvement in the quality of life and not aim for the moon. The process flow starts a day or two before surgery. After the patient is admitted, a planning MRI is done, and the planning is sort of initialized, about which we will see in detail later. On the day of surgery, under local anesthesia, the stereotactic frame is fixed, and this CT is fused to the previously done MRI, and the patient undergoes surgery, where eventually the final electrodes are put in. And after a CT confirmation, I tend to insert the battery under general anesthesia. This is at the end of the preoperative MRI planning session, where you can see the two red nuclei depicted very clearly and the subthalamic nuclei like the edges of a mustache around where the electrode target has been planned.
The images for registration. Typically the T1 weighted volumetric sequences done typically somewhere between 1 to 1.5 or 2 millimeter slices are chosen for the registration. The T2 images show the subthalamic nucleus with good clarity. Here you can see that the red nucleus is seen here well, and these are the two subthalamic nuclei seen on its side, like the edges of a mustache. The planning computer takes care of it. We start with planning, and for that we will need to first identify the anterior and posterior commissures. Again, for that, it is better done on a T1 image. See, the anterior commissure, posterior commissure, and mid commissural point are all mapped. And this is seen on the sagittal, and here it is seen on the axial as well. And once we have given the computer the these coordinates, then it can select the target on the left and the right side based on what target we are going to hit. Now for the left subthalamic nucleus, it selects stereotactic coordinates at 12 millimeter lateral to the mid-commissural point, 4 millimeter behind it, and 4 millimeter inferior to the ACPC plane. Now when the system shows you the point, then we can always tweak it by again going to the T2 picture, and we can aim for the dorsal part of the subthalamic nucleus.
Now, a few important points. Ensure that there is not much shake and image clarity then goes for a toss. Therefore, I am increasingly tending to get the planning MRIs done under full general anesthesia. On the day of surgery, as you can see, a Lexel frame is being inserted under local anesthesia, and try to place the frame as parallel to the ACPC as practically possible. Now, this is a CRW frame in place. Once this CT scan is done, we fuse the previously done MRI, and the system throws up the stereotactic coordinates, the coordinates based on the frame and how the frame has been mounted onto the head. Once we have that, we are ready to kick off with the surgery. The patient is brought back to OT and placed with the frame's base ring mounted onto the Mayfield system. Surgery starts with sterile cleaning, prepping, and because this is done under a scalp lock with minimal sedation, we maintain a line of communication with the patient. The patient's eyes should be examinable. The patient's hand should be free, where we can examine at the later stage. Now the frame is assembled according to the coordinates which we got, and according to whichever side we were going to do first. The burr hole here is being placed, and then the Stimulop system is assembled over it so that the electrodes can be securely fastened once the final electrodes are in place. Thereafter, the microelectrode recording system is inserted, and as many microelectrode recordings as we need are placed. I typically tend to do 3-channel recordings, and here you can see that good recording is coming from the subthalamic nucleus in the central channel. So this is a patient with severe Holmes tremor who underwent DBS, unilateral DBS here, because the other side is fine. And you can see the same patient during surgery. You can see that the tremor is completely abolished. So we can get good intraoperative idea of the adequacy of our electrode placements. So we meticulously record all the intraoperative MER data and the clinical macrostimulation data that will help us choose which channel and which depth to place the electrode in. And here, once this is done and the electrodes are in place and secured with the stim lock, we wheel the patient back to CT. And here you can see what the CT shows. For the orange side, you can see, and the pink side, that the electrodes, the final electrodes have gone in exactly where we wanted them to be and exactly as we planned. Because here you can see the MRI has been fused to the postoperative CT, and that's how you're getting the hyperintensity of the electrode in vision. And the final electrode is bang on target. Next, we bring a patient back to OT, disassemble the base ring of the stereotactic frame, again position the patient as we would probably do for a VP shunt, and the electrode intermediate incisions have been placed. And from here, from this incision to the infraclavicular pocket in the chest for placement of the IPG, there is a extension lead that is connected and the IPG is placed in. Postoperatively, the patient is in ICU for as short a period as practically possible. Thereafter, the patient is shifted to the room. While initial programming can be done on day 1 and 2, I have increasingly tended to switching on the programming only after suture removal. The patient is discharged again as quickly as we can and brought back later regularly for programming, which happens initially every month or so. And thereafter, once we've hit the sweet spot and the he's got the best trade-off between clinical effect and side effect, we tend to review them every year. Thank you for patient listening.